that initiative to take care that if you've been diagnosed, there are treatments available. The fourth pillar is palliative care. If you're not able to cure, at least take care of a good quality of time for the time that's left, and that people die at least in dignity and not with severe pains. We can repair. Arthur works on a trial. A very good treatment for pain reduction, much better even than morphine, because morphine decreases the quality of life, and lidocaine keeps your head clear, gives you a good quality of life for the time that's left. The fifth pillar is very, very, very important. It's awareness. We heard a lot about awareness. When people are thinking about witchcraft, when women are set out of the family because they have breast cancer or another type of cancer, this is something that we really should work on, because for early detection it's important, for treatment it's important, for diagnosis it's important. So we have 5 pillars: awareness, with prevention, early detection, access to medicines, and palliative care. That we started a company, and in that company is called OncoInf, and in that company is the product that Professor Mao just described. We have started that company for an important reason. Professor Mao already mentioned the price. It's a low price because he designed and developed his product for low and middle income countries. So all the things that the price must be as low as possible. So we use the World Bank classification for countries in low, middle and high income, and for low income countries we do this for cost price, for middle, a little above cost price, and for the rich countries we make profit so that our company is sustainable, because without any profit you go bankrupt, and that's in nobody's favor. So OncoInf is the company that we set up to make a sustainable product and to deliver a sustainable product, so that all the country benefit of that. Like I said, early detection, OncoSeek is a good product, but without awareness it is useless. When people do not come to the hospital early stage, when they have some symptoms, when they have complaints, when they come late stage, still the product won't be successful. And that's why I liked the words of Professor Rogo, who opened the session. Prevention, education and early detection is everybody's business, and I think he's very not only the people in hospitals, general practitioner, know it. We who need to be, who are responsible for prevention, early detection, education, etc. And I think there is a special role for patient advocates. And in your country, Inspired to Live works with Dr. Arthur Ayn, but there are also 3 fantastic women who are patient advocates in Kenya. It's Emily, it's Maria and Lucy, who are very, very active. Ilona, who is also in this call, Ilona and I met with these 3 women. Again, Emily, Lucy, Maria, at the case. These advocates can work on awareness and make people come as early as possible to the general practitioner, to the hospital for being diagnosed and being treated. Well, Dr. Shu already mentioned that the options are much better if you treat it early. She is a surgeon. We met her last year in November when visiting Kisumu and also Sangam Hospital. I think that surgery and that there is a good job to do, so Bill Ekwa already mentioned that there is a good job to do for the radiotherapy center in Kisumu. We're working on that together. We, in Scotland Live as a patient advocacy organ, Arthur, Professor Kisumu, it's not already clear about awareness and advocacy. We cannot people from government our responsibility in that, but I think it starts with advocacy. Thank you very much.
Is there anyone who has any question for the everyone is presentation, and of course there will also be cancer advocates. So, yeah. So our next presenter is Dr. She is from Kenya, Dr. Tendwa, but she's in South Africa. So welcome, Dr. Tendwa.
Hello. Okay. Thank you, Alka, every presenter. Seeing equitable treatment for all in cancer. My name is Dr. Tengwa. I'm a global health catalyst activist, and today I'll be talking what sought early diagnosis. We have been found with cancer, then we go for treatment, and we find that the medication that we are given are not really working on us, but they are being toxic. Why? What it does to the drug and how it affects cancer treatment. Then some of our people will continue suffering in silence or will not continue responding to treatment. And at Global Health Catalyst, we are working towards precision medicine where every individual diagnosed of cancer should be able to access treatment in spite of cancer treatment. What is pharmacogenomics? It's basically genetic variation in populations and how it affects how we metabolize cancer medication. Pharmacogenomics is These are two terms that can genetics. We are talking about a small population. Genetic makeup due to mutation, metabolize some or respond negatively to some cancer drugs. Just taking pharmacogenetics and looking at a subpopulation, a bigger population, a broader population, to see how and found that affected negatively by the drugs that they take. Drugs are produced in development benefit from these drugs. They may take these drugs and may not. It's happening. In our genetic makeup, that process the drugs that encodes proteins. It should be the ones that process drugs, metabolize the drugs. And these enzymes are produced from genes. These genes are known as pharmacogenes. So the whole process of encoding starts in the nucleus where the DNA is. So this DNA will transcribe a messenger RNA, and the messenger from the nucleus where it will produce a protein, very specific of chain of amino acid. It's just like information that is very sequential. And once a protein has been made, this protein to be. So for any genetic mutation to happen in the protein, it will deform the shape of the protein, interfering with the way it metabolizes a drug. Types of protein. We have different, this side as you see, the protein being encoded will either be classed as drug metabolizer or phase 2 drug metabolizer. On the uses to break down the drug. If it's or reduction, then it will be classified as phase 1 drug metabolizers. For today, as an exemplary, I'll use enzyme that's used to metabolize 5-chlorouracil. What is 5-chlorouracil? Third most common drug globally that is used to treat gastrointestinal cancers. This protein is encoded by a gene called dehydropyrimidine dehydrogenase. It's a pictorial of two chains. So the chain in the is chain 1, and the one that is represented as a ribbon is, picture of what happens once the drug is encoded into the protein active side where the drug anchors is of a redox reaction around the protein, and a third and cause DNA disruption and RNA damage to cancer cells. But what is interesting is just a third of that drug the body is then excreted, that is 95% of the drug, is then rendered detoxified, sort of detoxified, and get eliminated from the body, excretion through urine. However, due to genetic variation, it has been found that this drug cannot be detoxified by so many people. Hence, it ends up being toxic to the body. Basically, so this is chain A and this is chain B. Activates the protein, and this protein will then sense down to the where the drug is metabolized. But due to mutation, I've represented mutations in purple. This means it's just one amino acid at a certain location has been changed from the original amino acid to another amino acid. And it changes the whole game in the protein. So you can see, once in each chain, once the mutation comes, the communication around this other amino acid in the protein changes totally. Originally, it's supposed the amino acid communication is supposed to take place where the dark blue amino introduce you the communication. Most of the correct channels are being eliminated. There is no activity. That's how communication of sending messages to metabolize drugs, and hence the body will not metabolize those drugs. That is just in simple terms. And it has been found that when we take a population, we take that population, testing for any mutation of the DPD gene, you'll find that yes, most of us will be good responders. And then you'll find some people who have mutated medication, but it will not. But then very bad side effects. Unfortunately, some of these mutations have been identified in the African population. In Kenya, they tested this mutation in Webuye, and they found the Y186C mutation existing in that subpopulation. They also tested the Somali the Kenyan population. Not so when we do a lot of tests. machine learning and artificial intelligence just to model these proteins and to make this protein mimic the environment of a human body. And as we can say, when we look at this test, basically what it tells us, this is the native protein, and this is the native protein. When we look at the communication patterns within these proteins, they drag. You see here, when we look at violin plots, we look at how this is chain 1, this is chain 2 of monomer 1 and of monomer 2. So what we look at, monomer means basically is just chain A and chain B. So when we look at this function, but when we look at from what the native protein function, meaning that it affects the way this drug is being processed. And that is just an example of how mutation will affect how drugs are being processed. But then, how do we change this? We can change this by looking at other drugs that cannot be drugs that bind into this protein any of the active site, and those are called drug modulators. Or else we can look at drugs that have already in the databases that are used to treat cancer and try and see if they can be launched in this protein and drug been found to work very well in phytomedicine. We have so many cancer drugs that have been discovered from phytomedicine. And these drugs function so, just give me a minute. Oh, okay, my screen just froze for a little bit, sorry about that. These drugs have been found to treat diseases ranging from leukemia, breast cancer, and they originate from plants. We have similar plants found elsewhere in the world with the same or different combination of chemical formulas that have been found to treat cancer, but conversant of this. And we are now doing studies in phytomedicine and try and create suppositories like organization within Africa have created databases. What is the importance of these databases? With the drug database, we look at the ethnobotanical knowledge. Then we look at the in vitro and in vivo studies that have been done in animals, and we create these databases, like the South African natural compounds that has been created by the databases from the Central African medicinal plants. So they have all these plants with chemical compounds and they have diseases that they treat in one suppository. The importance of that is to create a drug base where when we are using computational methods, we can easily go to those drug bases and look for compound or lead compounds that can be used to produce new drugs, or that can be used to produce repurpose the drugs that exist. Such suppositories are used to get Excuse me, somebody talking? Such suppositories are used in this process, early discovery of drugs, and these drugs are tested and validated, and once they are tested computationally, then they can be tested preclinically about. Because once we take and we test these drugs in diverse population, then any pharmacogenetic resistance can be detected at this phase. And we can have other means, or we can have other drugs that also can be used to treat the same condition for people who cannot metabolize those drugs. And that is why it's very important for us now to as individuals, health catalysts that explores all these aspects in trying to find medication that suits the population. And we want to invite you all to join us. My colleagues say we want to invite you all in those that will commence from the 14th of June. Also incorporate eventually after we incorporate the pharmacology and how it affects how we process informative. To conclude, why am I pivot? And once we know how our genes will metabolize, how our genes affect the drugs that are used to treat us, then we'll know how we treated a certain drug who are showing toxic effect of the drugs. We can change the treatment medicine for all. That the drug that is used to treat you should be more beneficial than show toxic effects. Also, using pharmacogenomics, we will know how we can do gene editing to modify how it's by the body. Such have been examples, have been with like Chris, even like because to cause cancer. So such by things like artificial intelligence, use machine learning and even in cases of mutation, here today to know that, you know, this information about our genes, drugs for the benefit of humanity. Looking at key domains like pharmacogenes, AI catalysts, and I want to thank Uzima. Genetic to then influence the drugs that we metabolize, and how can we then counter this by also producing drugs that incorporate every gene
Thank you very much, Dr. You guys are muted. You need to unmute before.
Alright,
Thank you.
you can hear me now?
Yes, we can hear you, but your video is off.
Alright, so thank you so much, Dr. Tendo. Alright, come on.
Okay, thank you so much, Dr. Tanya. Tenma, for that presentation. My question goes to this, as we are talking of pharmacogenomics. Is there a mechanism that has been developed to do this genetic testing so that now we can start prescribing based on the predicted reactions or guided by that possibility of genetic mutations? And then when we're talking of phytomedicine, yes, the role of also laboratories and the way to test and start incorporating the conventional medicine.
Dr. Joan, you could just repeat them for me.
Alright, so he's asking, and let me start with the second question, is that there are policies in Kenya currently to legalize the cannabis-based, medicinal cannabis-based drugs we use in Kenya. And then number two is, do we have genetic testing, do we have genetic testing for patients to give them drugs that are compliant with their.
The second question is asking if there's any genetic testing done in Kenya.
Yes.
I think it's common to every person, because we find that most of these cases that this is, you know, affordable for everyone, so that when we go, especially in cases where we know that a person has a family history of, let's say for instance, let's take BRCA gene. BRCA gene, genetic test, or they receive treatment. So that's why we want to work as researchers, we want to work as clinicians, we want to work together to see that such tests are made affordable to everybody and are really put our mind together and forward. The first question, I never got it very well.
He was asking if
It
there's any.
came in fragments. I didn't know what he was talking about. John?
Yeah, he's asking if we Joanna or medical.
I'm still not getting it. It's online
Yeah.
as we go because CIA.
Alright.
Sorry about that.
Professor Robert, you're the policy man. Professor, do you have a policy on medical marijuana? Yes.
No, we do not have yet, and it has not been taken too seriously in Kenya. You'll remember that there is one strong advocate from CIA. People have not put at the side. That is not seen as another. Maybe Uzima University reputation may need us in research in this area. Thank you. And it looks like Professor Munga is shaking his head.
Yeah, you answered. So we are going to do some clinical trials on after the conference. So I don't know if we do one on medical cannabis for cancer patients for pain. Yeah, that's what's one of the things that they want us to do. So the next presentation is from Professor David Kerr of Oxford University Medical School. It wasn't available live, but he sent his pre-recorded video.
David Kerr, Professor of Cancer
David Kerr, Professor of Cancer Medicine at University of Oxford, which you can see behind me, the Doing Spars. I'd like to thank Arthur for this kind invitation to attend this important meeting. Apologies for two things. One, that I'm not there in person. I love Kenya, I love visiting, and I think you have a fantastic medical infrastructure. And secondly, that we're not doing this live. Today's my busy clinic day, and I just simply couldn't get out of it. What I would like to do is to talk a little about precision medical oncology and how we can embrace artificial intelligence and develop clinically useful new tools that will allow us to personalise the treatment that we offer our patients. I'm going to talk particularly about colorectal cancer, which is a disease I've studied for 3 decades. But I know you're having an important day talking about cancer prevention, awareness raising, and I think these are incredibly important topics when we look at cancer control. But let me focus, if you don't mind, on this particular subject. I've done this work with a increasing incidence in people under the age of 50, and therefore imposing a huge disease burden on the globe, and one that's increasing in sub-Saharan Africa. We set up the Quasar Trials Group some years ago in the United Kingdom that I led. Quasar means quick and simple trials. They're reliable. They are simple. We ask a very straightforward question, and they're quick because we reduce the amount of paperwork and data that we require to complete the study. So we focus only on the endpoints that are really important. And there's a model there again, I think, for global cancer trials. They should be quick, simple, and reliable. And we should be able to collaborate more, I would hope, between the great universities in Kenya and august institutions like Malawi in Oxford. We believe that adjuvant if you look at this pie chart, it shows that 80% of patients are cured by surgery alone. 16% died despite optimal surgery and chemotherapy, and perhaps an additional 4% were cured by us giving 6 months adjuvant chemotherapy with 5-FU folinic and therefore we can pose the question to our patients, our clinical colleagues, to the health economist: is treating 100 patients with essentially good prognosis as a whole population with toxic chemotherapy? 20% of patients will have significant side effects. Perhaps the toxic death rate will be 0.5%. Is it justified to cure an extra 4 patients? What we believe is that, of course, not every patient has the same risk of recurrence. So by understanding more about the biology of disease, whether it's colorectal cancer or breast or lung, the more we understand about the biology, the better we can develop biomarkers that may allow us to identify patients both at high and low risk of recurrence, and to use that prognostic information to personalise the adjuvant treatment that we might give. So that's the sort of the question that we posed. We know that many tools have been proposed for selecting patients. There are a number of existing conventional histopathological features: T-stage, number of nodes assessed, tumor grade, lymphatic vascular invasion. You see them listed here. But in terms of current guidelines, there are no molecular markers that have been really properly validated. If we look at mismatch repair deficiency, that's one area in which it does look as if patients who've got mismatch repair deficiency have got an improved prognosis. All of us now recognise MMRD, mismatch repair deficiency, as being a predictive marker for immunotherapy with immune checkpoint inhibitors. And this is because the frame shift mutations which have occurred in patients who have got mismatch repair deficiency leads to a huge neoantigen burden. So the colorectal cancer cells which are mismatch repair deficient present many novel antigens, and therefore that's what makes them such good targets for immunotherapy. And it also means that these are tumours of relatively good prognosis. In our practice, with early stage colorectal cancer, 10 or 12% of patients are mismatch repair deficient, and they've been found consistently